Okay, I think we'll get started. We're running 5 or 10 minutes a little bit later as we're letting people trickle in. Thank you for being here. Can everyone hear me okay? Okay. Well, good morning. Thank you very much for being here. Thanks, Neil Howe, for kicking us off. I'm sure you gave everyone a little bit to think about. Did you see yourself in any of the generations? Yeah. I think I straddled 2 of them. As I was looking, I could see myself a little bit in both. Only the good parts of each. That might just be me. Can I ask a quick poll of the audience? How many are from healthcare organizations? Okay. Thank you. Research institutions? Communities? Okay. Anyone I missed? That isn't represented?
Investors.
Investors? Okay. Great. Well, thank you. All walks of life are welcome here. We appreciate having everyone. And I think there will be something for everybody as I am able to introduce our panelists and talk a little bit about the topic. And I'd also like you to keep in mind what Neil Howe said at the beginning of his presentation about what will healthcare look like in the next 10 to 15 years. And is that something that we can predict and plan for? And I think our 3 panelists will have some ideas about what they're already doing to get to that end. So, my name is Mel Henderson. I work at the Center for Governmental Studies. I'm an assistant director there. And like many of you, I'm guessing, wear a lot of hats at your job. So, part of what I do is public management and training and strategic planning. I think I've worked with some of you. I see familiar faces. But part of something else that I do and I'm passionate about is research in healthcare. I've, for the last decade of my career, been very lucky to work with one of our panelists for many of those, and many people at CGS have in some ways worked with one of our 3 panelists. And so it's important to me to be here and be able to moderate this session, so I'm very excited to have been asked and to be a part of it. And so I think even CGS and those of us who work in healthcare think of ourselves more as partners in healthcare in DeKalb and in the region and in the larger state and in the information that we're able to provide. So we're very lucky to be able to do that here at the center. And my 3 panelists were selected because of that same dedication, and I'm going to introduce them here in a little bit later, but we refuse to let them say no. They are so good at their job and what they do. When we asked, we didn't really ask, we kind of said, come on over. So they graciously said yes, we're very excited about that. So when I was asked to do this session, I started to think about what am I going to say? I'm guessing lots of moderators, as you think about what you're going to do and how you're going to talk about a specific topic, that comes to mind. And so I started to think about a cliche that I've heard a lot, and I'm going to say it out loud, and I'm guessing you may have also heard it. The landscape of healthcare is changing. Everywhere you go, you hear that at conferences and research, and it is, but what does that mean, and what are some options and outcomes, and how can you adapt to that? So that was my question I kept going over. And what I came up with was, how does that pertain to what we're going to talk about today? So it's a little more specific with community and economic development, and that's kind of what we're talking about with this session. So I think that there's been a fundamental shift. And I've talked with my panelists via phone and also through several projects. And the fundamental shift is that healthcare used to be a place you go when you're sick, right? A hospital, a healthcare organization used to be a place when you weren't feeling well you went to. And that shift has been happening over time. It's not something suddenly that has happened through different changes in healthcare insurance, through different political issues, through changing demographics, like we heard about the baby boomers. There are some things that are happening that are out of the control, right, of healthcare and hospitals, but they're still important to recognize. And that focus has now shifted to proactive community development. Hospitals are no longer just a place where you go. They're respected as a partner in the community, not only for the care that they provide, but the community outreach that they provide. And so I think that change has been, they're viewed differently in the community, and again, by the community, and what that represents. And I think one of the other large reasons for that shift is that hospitals and healthcare organizations are one of the largest economic drivers in their communities. This is especially true in smaller rural communities, but even as a Swedish American that we're going to talk about today, I was talking with Marco a little bit earlier. 1,200 plus positions that they're a part of. So they're large economic drivers. And that's really easy to have a partner when you know that they're providing that kind of financial stability for your community. They also pay above wages, and they offer that ripple effect of the economy, right? You're spending money in your community. You are having higher educated people in the community. They're buying houses in the community. And so you get the ripple effects of having large employers in your community like the hospitals that we're going to talk about today. So, last water. So our panelists today represent a rural health network, a county government community service organization, and a large health system. So a question that, again, I ask myself, and you might be asking, is what is the common thread? So you have smaller organizations, rural, suburban, urban. What kind of can that common thread be? They serve often different populations. They have different financial constraints. While they all may work with Medicare and other different kinds of billing situations, it could be very different from rural to urban areas. And often the resources are very different. Some have foundations, some don't. Some have community, county health departments that are very supportive and aligned, and some are just learning how to collaborate a little bit higher. So lots of different things are happening. But across the board, having healthy residents for all of these areas, regions, the state, the nation, healthy residents are the foundation for a vibrant community. So it doesn't matter where you live, where you come from, what population you serve, being able to now provide that as a healthcare organization and system has become more important than it's maybe ever been in the history of healthcare and the change that it's experiencing. And I've talked to the panelists about a lot of different things, and you know, one of the things that always comes up whenever you're talking about healthcare is social determinants of health, right? So they're looking at everything from healthy housing, you know, housing that's livable for people in their community, to economic development and how can they continue to be that driver, walkability of their community, keeping people healthy longer, and all of these social determinants of health. And then on top of that, they also have a bottom line that they have to work within and help do things. So the cost of healthcare to both the consumer and to the hospital are very important when they're looking at how much community development can they help with, how much can they be involved in economic development, how important is it? And I believe after talking with the three ladies who are going to present today, that they walk that kind of tightrope of understanding what the community needs and everything that's healthcare related, but on the flip side of that, also being able to understand the economic and community development importance of their organizations. So I will get to the meat and potatoes of our session today. I have the honor, and I truly mean that, of introducing three distinguished panelists who will be highlighting how their organizations are embracing demographic changes, engaging with community outreach, and how they are measuring success in our ever-changing healthcare landscape. I'm going to let them do full bios. If they would like to, they can introduce themselves however they see fit, but this is going to be the order in which they are presenting, not the order of importance whatsoever. I should have just done alphabetical order. That would have been good. But Mary Keating is the Director of Community Service with the DuPage County Government. She is also the President of the National Association for Community and Economic Development and Impact DuPage Steering Committee member. Pat Scow is the Executive Director of the Illinois Critical Access Hospital Network and President of the National Rural Health Association. And Patty Duane is the Chief Financial Officer for Swedish American Rockford, a division of UW Health. So I just want to do a little logistical piece here. We're going to have them present and then save question and answers for after all three have had a chance to present, if that's okay. And also you have some note cards at your table. These are just some things that we're looking at in terms of issues, what you see in your community related to healthcare, and these are something that you can turn. We have a little box over here. You can feel free to leave them on the table. And we're going to take those and do some theme analysis, see what some of the issues are, and hopefully get back to the group about what they're seeing. So if you can fill those out before you leave, that would be great. So that is all that I have. I'm going to let Mary Keating go ahead and get set.
Well, good morning, and thank you, Diana, and thank you for the Center for giving me the opportunity to speak with you all this morning. You know, the topic we're talking about today is the intersection between healthcare and community development. And I'm going to start by talking about the intersection between community development and social services, sort of in the DuPage model. I think it's important to start with that understanding of our model, because that's really what allows us to further integrate ourselves into healthcare and collaborate with healthcare organizations. That collaboration, I think, is really highlighted in a project called DuPage, in terms of how we work together from a community development and healthcare perspective. And then I'm just going to take just a couple of minutes to talk about some sort of a promising practice that's happening in many regions, really all over the country, with a project called Fuse. So first I want to talk about, when I'm talking about community development, there's a lot of ways to define community development. It means a lot of different things. In different municipalities, the community development director could be talking about zoning. They might be talking about business development. But when I'm talking about community development within DuPage County, I'm really talking about those efforts to ensure the livability and sustainability of particularly low and moderate income neighborhoods and activities around affordable housing. So in a traditional model, community development and social services are often really directed by two different sectors. The public sector, the local municipalities, that's who's making determinations about the community development block grant program. They might be a home participating jurisdiction. Home is a HUD-funded program specifically to support affordable housing. There's often a local housing authority that, amongst their responsibilities, takes on a program called Family Self-Sufficiency, which is a long-term case management program to help folks who are either in public housing or living with the assistance of a voucher. It helps them to move towards economic self-sufficiency. And then in the nonprofit sector, we see those more traditional, or the traditional social service agencies, often broken into categories where they're sort of working with particular demographics. So you'll have a senior services agency that will be doing information and referral assistance for seniors. They'll be managing the community care program, which helps seniors remain in their home. Adult Protective Services helps investigate and support claims of neglect or abuse of seniors and people with disabilities. The Long-Term Care Ombudsman program works in long-term care facilities, making sure that residents have their rights protected and have a voice when they have concerns. You'll traditionally have a homeless services provider that runs the Homeless Continuum of Care, which is a consortium of multiple agencies all working to end homelessness in their community. Homeless Management Information System is a shared database for individuals who are working with folks who are either homeless or at risk of homelessness to help aggregate needs at a community level, and also helps with referrals across agencies. And then there's a specific, usually specifically designated nonprofit in a community that's called a Community Action Agency that works with federal programs specifically to help folks at or below the poverty level and works towards reducing poverty within their community. So a traditional model in most places in Illinois, and actually in most places in the country, those are very, very distinctly divided between the public sector and the nonprofit sector. So in DuPage County, through I think some very progressively minded people, probably in about the 1980s, we have a very different model in that the types of programs that I was talking about in the more traditional model, we do all those things within our single department of community services. There's clearly some advantages there from a client perspective. Folks can move much more seamlessly between different programs. We're able to help multi-generational families, which we see, I think we see more and more of multi-generational families with different members of the family have different needs for different types of social services. We can have kind of a one-stop shop perspective. The downside of having all of this within the government sector, I think one of the downsides is we can't typically be as flexible or as quickly responsive as some of our nonprofit partners in other areas of the state. So sometimes we have sort of a double layer of bureaucracy because we're managing state and federal funds, and then we're managing them within the constraints of local government. So that can be a challenge. But a way that can be beneficial to us, actually, and we saw that in the state of Illinois, particularly very challengingly a couple of years ago with the budget impasse, is that we as a department had sort of the full faith and credit of DuPage County government behind us. And we didn't have to worry as much about late payments from the state, where some of our nonprofit partners were really in dire straits. But from a planning perspective, so two of the funds that we manage, or a couple of the funds that we manage, come from the federal government, and they have a very specific planning requirement. Our community development block grant and home funds require something called the Consolidated Plan for Housing and Community Development. And our community services block grant requires us to do something called a community action plan. There's about an 80% overlap in the planning that's required for those two federal funds. And so, thinking about the traditional model, that planning would have been done in one of those plans would have been developed within the public sector, and one of those plans would have been developed in the nonprofit sector. And so we're able to sort of cross-inform those plans together. Both plans require us to do both qualitative and quantitative research on the needs of low and moderate income individuals, folks at poverty level or below, and then also some little deeper dive into some specific needs of veterans, individuals who are homeless, persons with disabilities. So internally, we have the opportunity to kind of join forces within the units that manage those and do some sharing of staff time, working on focus groups, those kinds of things. So internally, we have the ability to kind of strengthen both plans because of what we're able to do within our own unit. But what we decided to do this time around, actually both plans, you'll see one is a 5-year planning cycle and one's a 3. This year, actually, both plans lined up, so we were in the same planning cycle. So we expanded beyond just sort of our internal coordination, and we reached out to an organization that it's hard to call it an organization, right, Tammy? It's an initiative within DuPage County called Impact DuPage. So we worked very closely with Impact DuPage in this planning cycle for community development and for our planning for folks at the poverty level. So Impact DuPage, I'm not big on reading PowerPoint slides, but I think this one actually is kind of important. So the purpose of Impact DuPage is to create a common understanding of community needs, gaps, and priorities that will advance the well-being of the DuPage community. So that sounds like a lot like the mission of our organization, is to advance the well-being of our community. And to achieve this, Impact DuPage will engage community stakeholders in a coordinated approach to ongoing community needs assessments, resulting in data-driven solutions to address county priorities, align resources, and improve population-level outcomes. So those of you who come from local government, that sounds a lot like the Consolidated Plan for Housing and Community Development. For community action agencies, that sounds a whole lot like the Community Action Plan. And for those of you in healthcare, to me it sure sounds a lot like the Community Health Needs Assessment that all hospitals have to do. So it really is sort of a natural partner for us to work with. So Impact DuPage was formed probably, I think about 2012, 2013, a couple of years ago. And you'll see that the steering committee includes not just local government and not just nonprofits, but the health community, the healthcare sector is a really vital partner with all of us. So you'll see Northwestern is in there, Advocate, the DuPage County Health Department. So really, the impact page is where the government sector, the sort of nonprofit social service sector, and the healthcare sector have all really come together. I don't know how well you can see all that. I'm not the greatest at doing screenshots and putting them into PowerPoint. So there's two really critical things I kind of want to highlight about Impact Page. The first is that through Impact Page we have a community dashboard. And so what that does is really provides all of us who are working in these sectors with consistent, updated data that we can all turn to have a better understanding of what the needs and what the disparities are within our communities. For each measure there, it will indicate how we're doing compared to other counties. It'll talk about whether we're trending up or down, how we're doing compared to national norms. And you can filter down into that zip code level or community level. So individuals who are working in a particular municipality or hospital with a particular catchment area can really dig very deeply into the data to get a better understanding of what the needs and disparities are within their community. What that does is all of us, whether we're in the government sector, in the nonprofit sector, in the private foundation sector, in the philanthropic sector, we're all working basically, as they say, we're all singing from the same songbook. We're all turning to the same data, and that's absolutely crucial. One of the other roles that we play in the county is I read a lot of grant proposals from nonprofit organizations. And when you can see consistency of data across grant proposals, you really kind of understand that the community is working together. Everybody has a better understanding of what they need to work on. The other thing that Impact Page is doing is through a series of surveys and focus groups and all kinds of outreach that were done, both by sort of the infrastructure of Impact Page, which is basically some health department staff, as well as all of the various partners. They've identified these community priorities. These community priorities that really are cross-sector issues that impact each of us, every organization. Affordable housing is an important component for every sector. It impacts education, it impacts employers, it impacts individuals with behavioral health needs. So each one of these priorities is leveraging the knowledge of individuals across multiple sectors. There's also, through the steering committee, we have the opportunity for each of these initiatives to sort of inform the other. So it really is a collaboration of collaboratives. In some cases, these initiatives are working with, in conjunction with, initiatives that are already going on in the community, but they're sort of taking that learning and elevating it to a community level, and so there's sort of cross-pollination. And finally, I just want to talk very briefly about sort of a promising practice, or a practice that has been around probably 6 or 7 years in sort of various levels of engagement in various communities. It's called frequent user systems engagement. And what this model does is it really recognizes that there's a very small percentage of the population that intersects kind of the highest cost services across sectors within our community. So in fact, it's really focusing on people who are cycling through incarceration, homelessness, and emergency room and hospitalization utilization. So what it recognizes is clearly that's no quality of life for those individuals, and also it's serving people with the highest cost interventions that we can. And so from both I think it's one of those beautiful points where both from an ethical and an economic standpoint, they both point to doing this, to doing the right thing. And so, but it's very challenging. So not the least of which is the data sharing that's needed between those sectors, between healthcare, criminal justice, and social services. Just working out how are we going to share information and identify those really high utilizer individuals. And then once they're identified, then we need to think about how are we going to engage them. But in the places that it's working, as I said, that not only from an ethical but also from an economic standpoint, the results are significant. I think one of the biggest challenges is something that I've heard referred to as the wrong pocket. So what that means is that we know we've got these folks who are utilizing healthcare, they're utilizing criminal justice system, and at the very expensive intersections. And we know that if we can get them out of those systems and into some sort of supportive housing, so they're stabilized, they're no longer homeless, they're no longer being arrested for vagrancy or other sort of public nuisance kind of infractions. They're staying out of the emergency room. It's a much more cost-effective way, but it's not like now the hospital and the criminal justice system and the homeless shelter can now say, oh, well, I don't need that money, so I'll put it over here. So that's where it really takes a very high level of cooperation and an understanding that we need to kind of shift some of our funding priorities, and we need to just understand that by doing things a little bit differently, we can lower the cost of services to all those individuals. So the FUSE model is being used in areas across the country. Some of them are really focusing on more on folks who are sort of in re-entry from previous incarceration. Others are focusing on folks who are chronically homeless. Sometimes those are the same people, and sometimes they're not. So just to end, I think everyone got getting copies of these. So what I wanted to do was just sort of highlight some resources for individuals who are interested in anything, finding out more about anything that I've talked about. I will just take 1 second to plug both National Association of Counties and the National Association for County Community and Economic Development. Those are both professional organizations that I'm involved in. I'm the president of NASED currently. I just want to emphasize what the engagement with professional organizations has done for me personally, for my professional career, depending on where you are in your career or if you have staff coming up. I can't say enough about the importance of being engaged with national partners, really to learn from what others are doing. So thank you for your time, and I'll turn it over to Janelle, and then I'll be happy to answer questions at the end.
It was a great expertise in what you're doing and an example of collective impact. I know DePage has been working on that for a very long time. Even when I first came to the center, I know it was kind of getting initiated. So thank you for sharing. I already have some questions for you at the end too. So, and now I'm going to introduce Pat Scow. She is the guru of all things rural. So I will get her started here.
Thank you very much. Can you hear me well?
Yes.
Okay, wonderful. It is really an honor to be here, and I really have enjoyed working with the staff at CGS for a number of years. I worked with Mel and Norm, and they've done some wonderful papers for my organization, and of course with Diana in a leadership role. And it's just really an honor to be here and share the stage with them. A second reason I'm thrilled to be here is that I have a little NIU in my heart through the generations. My mother went back and got her teaching degree in the 60s when I was a baby boomer, young girl, and I had to learn to be independent, and she was going to show me how to do that, that individualism. But anyway, so she would come up to NIU, and I would go to the university schools in the summer, so I got to learn a lot about NIU, and of course, I grew up in south of Shabana, Illinois. I know they mentioned that today. I went to school at Shabana, and we would come up here and hang out, and learn about college life, and took piano lessons here and so forth. But and then later on, I had a chance to get my master's here and at the School of Nursing here in community health. So it was, it's really kind of a tug in my heart. And the third reason, it gives me a chance to really talk about rural health care. And I think that's why Mel wanted me to talk. I'm very passionate about it. I grew up on a farm. I'm a nurse by background, and I've had a chance to really work with rural hospitals and rural programs throughout my career. So I'm going to really take you into a deep dive about rural health care and hopefully talk about some issues, because really health care in the rural community, it's really hospital-centric for the most part. It's become that. When I grew up in the Marcus Welby days, many of you remember Marcus Welby, you had a physician in every small community. The community closest to me on the farm, because I was on the bottom end of here's DeKalb County, and the other side on our farm was in LaSalle County. But we went to Earlville, and they had 2 physicians growing up. And now, of course, most of your physicians are in your little bit larger communities, and I right now live in Princeton, Illinois, in Butte County. Anybody know where Princeton is? Yay! All right. But anyway, rural health care has really changed, and I'm going to talk a little bit about that. And the slide up here I have is really about what it looks like today. I don't think it's anything different to you that, the landscape, we're mostly all the landscape in the country, and yet we have a smaller population. It's changed. No longer do we have families, the farm families having 9, 10 kids, and the farm has really grown, and it's really become a little bit older, and you're starting to see that divide, and the speaker prior to me, really didn't get too much about the generational divide for rural, but he started at the last question. So there really are some issues that we are facing today, and that are different, and that takes into consideration if you're looking at the rural community. It's still a good place. We have an investor here. I still invest in rural because, we're really the economic engine, I pretend, in the country, because you have food at a very reasonable price. You can vacation, you drive through us, you have natural resources, the mining and things like that. So, really important that you understand the rural health trends and concerns so that we keep the community vibrant. But we do have our challenges as it begins to change. We have, economic trends. We have diabetes, COPD, and some of that has to do with COPD from farming and mining and things like that. And you can see a list of the top causes, heart disease and so forth. I don't think there's any big surprise to you on all that. And of course, a few years ago, we didn't think that there was an opiate crisis in rural America. I had gone to a conference with Rural Healthcare, National Health Association. They were talking about opiate addiction in rural areas. I go, what? No, that's really in inner city. That doesn't happen in Princeton, Illinois, or Shabana, Illinois, or in that. And come to find out, it has really accelerated. And then you start pulling layers down, and you start looking at that. We have an increase in suicide rate among young people and the social isolation. So, we really do have our challenges, and we're finally on our awakening. Some of the other issues is, I think it's no surprise in healthcare, and I'm sure my colleague over here, Patty from the university setting and tertiary care setting, will talk about chronic diseases, and we sure have our fair share of diabetes and COPD again, and cardiovascular disease and so forth. And you can see it really is predominant in our rural areas, and you'll see some of my slides as you move forward. We don't walk to school. We're not out there baling hay in the summers or walking. We have tractors to drive and things like that. So there's been some real changes, and you don't have a grocery store in every town. So a lot of things have happened. The other thing that's been an insult to our rural communities, and as I started my conversation, is that in our communities today, in our rural areas, the hospital is really the centerpiece. You know, healthcare really revolves around the hospital because it's probably the most economic in the area. It has the most resources. And, excuse me, and we have, you know, right now since 2010, 118 rural hospital closures. That's really scary. We had one in Illinois, and that was Streeter, Illinois. And I won't go into those details. That's not the purpose of the talk today. But it's really a problem because, you know, it's the economic engine. You're having people having to drive, and you have industry not wanting to locate in communities because there's no hospital, there's no health care. The other thing that keeps wanting to slip to this slide is that maternity care has disappeared in our rural communities. You know, almost every hospital, small hospital, delivered babies, and they don't anymore. We have moms having to drive, and it's really a crisis, and our healthcare system hasn't supported that. We don't have physicians delivering babies in our communities, so those are challenges for our. Now, we have our infrastructure. You know, we have to be concerned about that, EMS systems, and because, you know, you are having industry, you have farm accidents, mining accidents, you got to be able to get people in and out and get them to the hospital and so forth. But what's happening along with hospital closures, we're having long-term care facilities closed, rural health clinics closed, and things like that. And you don't see pharmacies and local stores in our local communities. And so, you know, we're really having to look at our community and our infrastructure, community health needs assessment. And what we're finding, instead of grocery stores, we have Casey's stores. And I love Casey's. There's nothing wrong with Casey's and dollar stores, but often those the food is not always what you're supposed to be eating, even though I love their donuts. So. And then, you know, we have the healthcare system changing, and I don't think that's any different from my colleagues over there, is we're seeing changes in how we're going to be paid. It's going to be, you know, people are still concerned about the high cost of healthcare, and I know that rocks economics all today. We're having Medicare itself moving to managed care. We know that now in 2019, 51 to 53% of Medicare beneficiaries now are in an accountable care organization or Medicare Advantage plan, which means that it's under some kind of managed care program. We know that states are being paid globally, one payment every 2 weeks from all the different carriers. Those things are happening, and Medicaid has really given up being the the insurance company for Medicaid beneficiaries. You know, they now source that out to managed care organizations. So all those things impact our rural communities, and we have to be able to know how to deal with that. So why does rural matter? I told you from the beginning of my conversation, the food you eat, you know, the vacationing and all those things, yes, that matters. But also, one thing that happened was the election. You know, some things, policy and all those things matter. 80,000 farmers feed our country. When did that change? And how does that happen? So, you know, we have to pay attention to that. As the economics of the farm community, how does that affect the economics of the rural community? And healthcare has to be that infrastructure, no different than education. And because rural mattered in the election, we're finally seeing some attention to these issues. And I think that brings out some of the things that we have in our challenges. What's interesting, I work with, run an organization of 57 hospitals. 51 of them are small hospitals, 25 beds or less, people would wonder, and others are a little bit bigger than that. And I asked these CEOs that live in these small communities from Metropolis to Galena, and they're telling me their biggest concern is the economics of their community. The economics of their community. And so they understand their new role as being the catalyst of their community and how important that is. And how population change and social determinants are impacting how they do business. So Melvin asked me to talk really about the non-traditional role, and Mary did a great job of explaining how DuPage has changed over the years from traditional roles to non-traditional roles, and how you begin to look at the community and the importance of social determinants in the local community, and how you identify patients, you know, and you're looking at the community. We're now managing our populations, our local health care. and mental health and local services in our rural communities. If we're going to be viable and plant corn and beans and raise cattle and chickens and things like that, we have to have support services. And as social isolation increases, how are we going to get those needs to them? And so we have to rethink the local needs of our people. Now that's just a snapshot of Princeton. For those of you who've been to Princeton, I hope you recognize that. And we're having to ask tough questions. And we're having to think about care coordination. Because before, when I grew up, you went to the Marcus Welby's, the local community, and he gave you medicine or she gave you medicine and took care of you. Now we're going to, long-term care, rehab facilities, and things like that. And our changes have really made a difference, and we have to be able to coordinate care. Our rural community patients have to be able to go from one place to the other and then back home again. We've had to learn to understand about our populations locally. We actually run an accountable care organization. I have 27 hospitals that have come together across the state of Illinois, and we're managing the care of our patients. We have the average cost of a Medicare beneficiary in our rural community is $12,400. Okay, this is just a Medicare patient. You multiply that by 44,000 beneficiaries. How many millions of dollars of health care are we responsible, and are we doing a good job? And are we using those dollars well? Are we using the money for social determinants? Are we helping people get their medications? Are we getting wellness programs and so forth together? And those all things are economics of the community, and that we have to invest into them. And that's, in the community, your hospital is in a community of like the size of Princeton, you would probably have $70 million flowing in and out through that hospital. And I know Norm Welser and others, and if you remember former John Lewis, they did a lot of study on the economic impact of that. So community resources make such a difference. We're having urgent care centers. We wonder why there's so many visits in our emergency departments. It's because there's no place to go after hours. But we're getting better at that. And one thing about rural people, maybe we're back at the old the silent or the GI group where you figured everything out. We're becoming more innovative. We're having urgent care centers. We're opening up programs after hours, and we're making a difference for that. And one thing that we can do is be community. So which generation do I fit in for community? Is that the millennials? But anyway, we reach out. You're seeing communities, instead of just coming in and having your gallbladder out, you're coming in there for Tai Chi. You're coming in there for your dietitian to help you better manage your diet. They're often the ones that raise money for cancer research. They're the ones that are doing CrossFit. Many of our hospitals, they have walking trails where the community comes in and does that. They really become the center of the community. And like I said, we really are hospital-centric and in the rural communities, and they're trying to raise awareness. And we're trying to keep people healthy, and that's very, very important through that process. And we have all the social services and things that Mary nicely went through. But we just have to do them in a different fashion, and we have to realize that sometimes socialization and distance, we have to be accountable for that. You might find this interesting. Across the state of Illinois, from the top to the bottom, we have 51 small hospitals, and you're probably wondering, are they all part of systems or are they independent? Right now, we have 33 that are still independent, government-owned, and the other ones are part of systems. But one thing you know for sure in rural, and maybe that's part of the generation changes, is that we all can't do it alone. We're not an island anymore. Even though we're resilient, we're island. We're not an island. There are things that are concerning to us as workforce, and how do we recruit? You often hear that less than 9% of the physicians work and live in rural communities. So how do you keep care of 20% of the population? So we're seeing where we now have EMTs. They come in and they provide some of that care. We have community workers to help people with diabetes and other things like that. So we've been learning to be innovative, and we have the creative solutions. But we're also facing an aging workforce. And we have a number of, I remember as a young nurse in the community, at the hospital, we had many of the women that were wives of the farmers, and the kids were raised, they came back, and they they were registration of the hospital, or they were the nurse, they were the nurse aide or whatever. We don't have that anymore because of when we went to the workforce before that. So we're having to recruit and find that new population. And I'm seeing something interesting in Princeton. We're seeing the return of the millennials, and they're now the ones that are opening up stores and wanting to work in our hospitals. So for rural facilities, we have to understand what we're doing and how we can keep people locally so that we can be that economic engine. And we want you to be passionate about us too. And we need to take care of our neighbor too. So for tomorrow, we have to build partnerships. I have to build partnerships with the Swedish Americans, with the OSF and others, because we really are seamless. We have to move to that so that we have a better situation and that we leave something better for the next generation. But we also have to compete, and we have to be our very best. So I run a network, and you can just see it of hospitals spread throughout the state of Illinois from the top to the bottom. And we serve 1.5 million residents, about $2.5 billion. So I think that's a little bit of an economic engine in itself. And we employ more than 16,000 employees. So, and that doesn't account for the business that comes out of it. You know, the pharmacies and the social services and the in-home, the home nursing and the long-term care business. So, but regardless what it is, and maybe that ties into the generation, we have to care about the people. And when it's all said and done, the business is still about taking care of the patient or our community. And if we can't put that first foremost, whether it's economics or not, we cannot move ahead and leave something better to the next generation. So thank you. Your next panel.
You truly are the champion of the rural causes, and that was a really great presentation, and I think it speaks to population health management and also, like you talked about, some of the small margins that rural hospitals are working under, so it's so important to talk about these issues. We have Patty's pulled up.
Thank you for having me here today. I am pinch hitting for someone, so my slides are a little professional. Some of the ones that preceded me, I apologize for that. And I'm really happy to be here too. I graduated from U in 1984, and not a lot has changed since I graduated. It's still cold as you walk through the center area, and the parking is still pretty limited. So I did find it. But, you know, it's a great honor to be here and come back and represent Swedish American and let you know some of the things we're doing. And it's not just rural hospitals that have challenged with margins, and I hopefully you'll see that as I go on here. So a few years ago, actually more than a few years ago, we changed our mission at Swedish American, and it wasn't strictly around healthcare anymore. So our mission is to excellence in healthcare and compassionate service. We care for our community. So it's not just healthcare, it's service, and it's our community as well. So we realized that there needed to be an intersection between just taking care of the sick and the communities that we serve in a broader vision. Our vision, though, has been replaced because we became part of the University of Wisconsin Health System in 2015. And their vision is remarkable healthcare. So we're following that because they're a teaching university, research. They really are driving a lot of change in the healthcare environment, and we're very proud to be part of it. This is the history of Swedish American, and you know, for a long time, the traditional, you know, we build buildings, we create access points for people. That's really what healthcare has been about in a lot of ways. And access is really important because we do have to take care of everyone regardless of their ability to pay, right? We have a lot of people who are impoverished who come through our walls, and we have to create access points for them. But we're facing challenges just like any other healthcare institution. Some busy slides, but you know, the population in our area that we are serving is expected to decline and have a decline of about 2.2% over the next 5 years. And even worse, all of us who are baby boomer, on the very end of baby boomer, but you know, we're always having more Medicare. And A lot of people who aren't in healthcare finance or healthcare in general don't realize that hospitals and healthcare systems actually lose money on every Medicare and Medicaid patient that comes through our doors. And of course, in the self-pay arena, that is all written off, that's given away. And, the crazy amount of gross charges that we have, it's been really under scrutiny lately, right? Trying to publicize our charges and holding hospitals accountable, which I don't disagree, we should be accountable, but those gross charges ultimately, at the end of the day, mean absolutely nothing. What we get paid is based on the contracts we have with Medicare, Medicaid, and our managed care. And the only place really healthcare institutions make any money anymore is in the commercial managed care arena. So your Blue Crosses, your Aetnas, your Humana's, and they're having increased pressure as well. So they try to pass that down to healthcare institutions, and no one's wanting to pay us more, right? Everybody's wanting to pay us less. At the same time, we have increasing costs from both the very highly skilled labor workforce, implementing electronic medical record this past year, implemented Epic, which I don't know if you've heard of that, but they live in Wisconsin, they're in Verona, Wisconsin, but very expensive for us to implement. That alone increased our annual operating expenses $6 million a year just to have that system. So all of those costs are increasing, and yet at the same time, the reimbursement streams are being challenged. Our amount of self-pay that we're writing off in terms of charity is going up. The Affordable Care Act, when we took out the individual mandate, that is having an impact because people are dropping that insurance. We're also seeing the impact, some of the impact of people not wanting to apply for Medicaid now because of the threat of the public charge. If you are public charge to the United States of America, you might be deported. That's an extreme threat for people, and they're not willing to put themselves out there and take that risk, so they continue to be in self-pay mode, and we write off a lot of that in terms of charity and bad debt. Put all that together in a pretty stark realization of the financial situation we're in, and at the same time, what we're trying to do is take care of people. The county health rankings for Illinois, Winnebago was 102 out of all the counties, and pretty negative. A lot of red there. There was nothing in the green, a couple in the yellow, but pretty negative in terms of how we're doing. If this was a report card, not doing very well. I'd say this is really a failing level. When we talk about social determinants of health, and in our community in particular, we have a lot of crime that we're trying to battle right now. It's been a real challenge, but social determinants of health, about 20% is accounted for from access and quality of service. All these things we're spending lots of money on trying to do, but 80% of it's the physical environment that people are working in, whether they're homeless or they have addiction struggles that they're facing. All of those are the bigger picture, and yet we're spending all this money on trying to take care of people and keep them out of our institutions in terms of healthcare, but it's really kind of a losing battle. And this is a stark realization. When you look at that map, where we're at, this is the heat map of life expectancy. We talk about, the Rust Belt or the Midwest, really, take the farmers and all of the agriculture and what they're breathing in and things like that have a significant impact on our life expectancy. So we're not really bending the curve either. This has been staying this way for quite some time, even though we're spending lots of money on healthcare. So, we talk about social determinants of health, and for, a lot of us, it's a buzzword, right? But for the people who are really dealing with this, and I'm also going to take a moment to read this. Alex Azar is the Secretary now of Health and Human Services. Social determinants of health is an abstract term, but for millions of Americans, it's a very tangible, frightening challenge. How can someone manage diabetes if they're constantly worried about how they're going to afford their meals each week? So food deserts, access to healthy food. How can a mother with an asthmatic son really improve his health if it's their living environment that's driving this condition? This can feel like a frustrating, almost fruitless position for a healthcare provider who understands what is driving the health conditions they're trying to treat, who wants to help, but can't just simply write a prescription for healthy meals in a normal clean air. So it requires new models to try to fight these challenges that we are facing, opportunities and challenges. paying for value, not volume. So, now the way we're paid is when somebody comes and sees us. And that doesn't apply to some of the value-based, the Medicaid managed care, things like that. But in most of the payment streams that we have now, we're still paid for the volume, the number of clicks, the number of people that come through the door. This isn't going to change unless we recognize that's flawed. Our existing regulations and laws and rules have not kept up with this basic change in our country. New payment models are needed to help address this. And funding for the work at the federal, state, and local levels is siloed. It's still happening. The future will require us to blend and braid funding streams to address gaps in social determinants of health. And that little guy there, it feels like we're running faster, but we're getting nowhere, right? We continue to throw lots of money at this, and we really need to have some solutions. And one of the things we have been a partner with is, in actually all three health systems in Rockford, there's a lot of competition in healthcare, which, let me ask you my personal opinion, I'll tell you that sometime. But, there's a place for competition, but I also think it can be a deterrent to really moving the ball forward. But all three health systems in Rockford, Swedish American, Javante, Mercy now, and St. Anthony, so it's all support the Rockford Regional Health Council. And this is a community forum where the members work together to try to address health issues, building a culture of health, coordinating this healthy community study. That is also what we utilize the resources of the Center for Governmental Studies here at NIU to support the research for that. It's a critical piece of that study. They support priorities and well-defined goals and measurable outcomes. And I'll share a few of those with you today, and then how we also take advantage of some of that. The community study really is a broad base, and they go after both clinical and social determinants, trying to determine, what is the lay of the land in the area that we are in, and trying to make progress. And so that we're able to use that information to build our programs and work together collaboratively. It's broad community involvement, stakeholder representation. There's a number of folks that are involved, and they actually have a study on their website that's published. And what happens with that very important study, it's done every 3 years. So the results and uses of that data, Rockford Regional Health Council, they identify community priorities and strategies, but health systems, we study that data, and we use it for our community health needs assessment. And that came out of the Affordable Care Act of 2008, where hospitals have to, every 3 years, produce a document that is a community health needs assessment that says what we're doing, why we're doing it, how are we measuring our outcomes in relationship to that. And, that really wasn't that long ago in the grand scheme of things, and I'd like to see it evolve more, but we have utilized it for building programs, and I'll talk about a few of those in a moment. Other organizations use this community study as well. The government uses it for planning and development. Our YMCA uses it as well. United Way, Winnebago County Health Department. Social service agencies will use this for grant requests, and the foundations within our community will also use it for grant development and allocations. One of the programs that came out of this for the Rockford Regional Health Council was called Changing Hearts, looking at the disparities in cardiovascular health. The role of the Rockford Regional Health Council in this is that we're not the provider of health care, but they're a catalyst, a convener. They empower sites to take ownership of this particular program. And with the outcomes there, it's pretty impressive. They had participants, 1,310 participants. They actually had a blood pressure change of 8 millimeters on average of stop blood pressure. So, that is really significant. I'd like to be off blood pressure medicine. I'm sure a lot of other people would be. It empowers participants to take charge of their own health. Site coordinator and ministry leadership, so the connection of spirituality as well. And it also increased the trust. There's a lot of distrust in minority communities with those who are in positions of power, so this is really an important part of reaching out to people. Also, very important school dental program. Dental health, I can't tell you how many people come to our emergency room for dental issues. And it's really sad that they don't have access to good dental care. How many of us take that for granted, right? Go to the dentist 4 times a year. You got to have it, you get it billed, you got to your health and your body. So what they did is they provided access to students within the school system for 8 years. And their role has been providing opportunity for those individuals and organizations to work together. Expected outcomes, 10,000 students annually receive oral health care. That's an amazing number. And they're creating this as a local and nationally recognized model. Another program that they have is the school-based health clinic. Again, similar to the dental, it's the largest fully staffed school-based clinic in Illinois. They have services available for those that are unable to access healthcare elsewhere. And again, regional health council's role is to act as a catalyst in removing those obstacles to better health. Anticipated and beneficial outcomes, over 3,000 students. So those are people who would really have gone without healthcare that this program has been put in place. The other thing we do is advocacy. They have an annual forum on Medicaid managed care. You know, I feel for people who don't understand how healthcare financing works because they come to our patient financial services area totally confused by the bills that they get. They don't know what's available for them. And this is a really important advocacy event so that people have an opportunity to understand what's available. Sometimes it's just like, you know, the greatest kept secret sometimes, and people aren't even aware of what's out there for them. And these are really complex rules to navigate when you have to apply and enroll, and, you know, so people can be very easily confused. So it's a very important advocacy effort on their part. There's all kinds of collaboration from Rockland Regional Health Council, but attendees include healthcare providers, office staff, and then critically representatives from the Medicaid managed care organizations, so we can hear from them. There's been a lot of criticism about Medicaid managed care in the state of Illinois, and how it was fractured. It didn't roll out that well in the beginning. It's getting better, and we have the Illinois Hospital Association that really helps us move forward on those advocacy efforts to make sure that, you know, managed care organizations are being held accountable for doing what they are receiving that stream of revenue to do. They also get the opportunity to hear the updates on those rules, very complex again. And the outcomes, they created a comprehensive billing guide working with a local organization, and then they had a survey that was created indicating that relationships have improved between managed care organizations and providers. So then as far as Swedish American, how we fit into this right now is the community health needs assessment. As I said, we use that. All hospitals have to post this publicly, what the assessment is, what their priorities are. They also have to post what the implementation plan is. So if you go to any hospital's website, you're going to be able to do a search. That's not easy to find, but do a search on community health needs assessment. You'll find this kind of information, what they're working on. So for us, the priorities became cancer, obesity, poverty and unemployment, access to medical care, dealing with our vulnerable populations, heart care, maternal, prenatal, early childhood health, and substance abuse. And you see how these line up with a lot of the things the Rockland Regional Health Council is doing and making efforts. And we have the implementation plans and what our metrics are going to be. We're in the process of implementing this. We just completed our most recent one. So some of the successful programs that we've had related to the community health assessment is mobile integrated health. Mary talked about the FUSE program that they have, and we have a lot of people who come to our emergency room. They call the ambulance, come to our emergency room. It is obviously not an emergent situation, but you know, they need to be seen. Sometimes it's really socialization. It's really what the issue is. But we're working with the fire department to create mobile integrated health, where we actually do outreach to those people in their homes, go to their homes and help and assist them, identifying what their needs are. It's been a very successful program. We have followed a few of the folks who have high utilizers of our emergency services, and we saw a decline in the number of visits that they make to our emergency room. So we feel that that is showing some success. We're in the process of working with the city of Rockford to develop a family peace center. At the root of a lot of healthcare is domestic violence. And this family peace center is to be a place where people can go and get access to the resources that they need, not just healthcare, but other resources to be able to navigate some very difficult social issues that we have. Solaris, this is I'm not going to try to tell you what the name Solaris stands for, but I'll tell you in short. It's dealing with the opioid crisis. We have received a federal grant to deal with that, where we have what we call a warm handoff. We have people who are in charge of this program who are former addicts, who they are really the care navigators or help the people who are trying to get off of opioids, and they are constantly in contact with these folks, kind of case management for those people. And the federal grant that we have is the money that we use to pay those individuals and keep them connected with our organization and with the people that they're trying to help. It's very early stages, just started in March of this year, so we're anxious to see what the outcomes are, but I think anything we put at this is going to help bend the curve here that we've got. One of the other things that Swedish American has done is called an investment in urban renewal. The area surrounding our hospital, it's a lot of impoverished neighborhoods and not a safe environment for our patients, not a safe environment for our associates that work with Swedish American. So we have tried to do renovations of homes, offering some grants to help people renovate their homes, buying some properties, developing green space, working very closely with the city to make this happen. And it's been very successful. At this point, we're kind of on a slowdown on that because we spent a lot of money on a master facility plan for our organization. We're building a children's tower. There is only so much money to go around. And we felt like we had kind of reached a peak of where we wanted to surround our existing hospital. But the crime in Rockford is really a problem. I'm sure you guys hear about it every single day. It's pretty scary. So it may be, as soon as we get doing the master facility plan, this is the next opportunity for us to get back into trying to improve the neighborhoods. So this last slide is just from a book that we read as a leadership team at Swedish American, the 3-box solution, where you should be spending your time. The present, that's really the daily work that we do. Of course, that consumes a lot of your time, but you don't want to spend all your time there. You also don't want to spend all your time in the past. You can learn from the past, but you have to learn and want and dwell there. But really, the majority of the time that we should spend is on our future. And as soon as we can make some inroads into social determinants of health and figure out the government funding and the revenue streams associated with healthcare, I think we might have a solution. But until then, I think we're going to be that little blue guy running faster and harder at the same problem. And that's it. Thank you for your time.
Thank you very much, Patty, and the rest of the panel for your unique perspectives on healthcare. We do have about 5 or 10 minutes, and I thought it'd be good to open it up to questions. And if you don't mind, I'll kick one off. This one's for Mary. I wanted to ask, with the collective impact and everything happening in DuPage, it's not easy to get all those organizations to work together. Can you talk a little bit about what it took and how long the process was in order to get where you are and seeing Impact DuPage really starting to have some inroad?
Yeah, thanks for that question. I think, so DuPage has prided itself for quite some time on what we call the culture of collaboration. It really has been it's just been a way of, I've been working for DuPage County for 20 years. And so I sort of walked into this culture, and there were some sort of key individuals along the way who I think really nurtured it, really gave it a title, sort of this expectation. I see a colleague, Tammy from Northwestern, is absolutely nodding in agreement. It's kind of how we do things, I think, but it's absolutely something that needs to be nurtured and needs to be cared for and called out. As we've had new executive directors or new leadership come into the county, I think folks reach out to them just to kind of have a conversation. There's sort of, it can be tenuous at times, for sure. But I think, I feel fortunate that I walked into that environment 20 years ago, but I think that we, for whatever reason, I think part of it is we're sort of, we're big enough that we've got a fair number of resources, but we're small enough that sort of the key leaders in all of sort of our major institutions all know each other pretty well because we spend a lot of time together. Many of us serve on multiple boards together. So I think the Impact to Page project has benefited from that sort of collaborative infrastructure that we've had for some time. So I don't know that I don't have any great advice for somebody who does it, but somebody this morning, I think it was the university president, said that relationships are resources, and that really struck with me. That absolutely, that absolutely is the case in DuPage.
Thank you. Other questions?
Okay. I have a question about for Betty, because you mentioned the opioid crisis, in our area, and it makes me worried about on one side, that's a national crisis, but on the other side, we're trying to legalize the entertainment marijuana, and a couple of cities in the state, they kind of debate whether they should allow the store to sell the marijuana. And I'm just wondering whether this could cause a negative impact on the community, and how shall we raise concerns about it? How do we address that?
That's a really interesting question because, I personally feel like that's going to be the next crisis because, that could lead to lung diseases. We've just recently seen the whole thing with the vaping. We think that's safe. And I don't think we know enough to really know for sure, but I believe that it will be in 5 to 10 years. That will be the next crisis that we face. And here's where you get to the conflict of priorities, right? I mean, we have a state that is fiscally not doing very well. They see an opportunity to raise revenues. So it's a difficult choice amongst difficult choices. I wish there were alternatives. So if that investor wants to drop a load of cash on the state of Illinois, we greatly appreciate it. But it is a real challenge. We face that in our institutions every single day. You make difficult choices amongst difficult choices, and none of them are really good. I mean, and even, Rockford would be in a casino. A lot of people are excited about that because, okay, there's jobs and there's trickle-down effect of that, but there's addictive personalities that are we're going to have to deal with. So there's never been, there's always an action. For every action, there's a reaction, right? That's the law of physics, right? And so eventually, I think we're going to see this come home to roost in our institutions. So we need to be prepared for it and not be caught off guard like we were with the opioid crisis. Does that help?
Yes, thank you.
Other questions? Marco?
I have a question for Pat here. You were talking about managed care for Medicare and 53% or something moving to. I thought that was good news. It's not good news.
Well, it is good news in capacity. The reason I pointed out is because many people have been blinded in our rural communities, small communities, that you won't have to work with others and physicians and hospitals working together. That's new, really, over the last several years, that they work together for your health care and that there's one process for that. It's not that it's not bad, it's good, but it's a change. You talk about change in healthcare delivery. And what's different about it with Medicare is that it's trying to get senior citizens involved with one organization. Right now, as a Medicare patient, traditional Medicare, you can go anywhere in the country and use whatever you want to. In a Medicare Advantage program, you're either in-network or out-of-network. You might pay more if you're not locally. And if you go, let's say you're in a managed care program in Rockford and you go to Florida, with traditional Medicare, it doesn't matter. But with Medicare Advantage and some of these other managed care programs, you might have to pay more out of pocket. And that's why, you have to think about those things. And the government would like everybody to move that because it's hard to control healthcare costs when you kind of have carte blanche to go wherever you want. And we all love that. but no politician is going to run to change that. So, so what they're trying to do is encourage people by performance, having, you know, programs that people get better care, better service, promote health, and by keeping them locally and taking good care of them, prevention and so forth, that will reduce cost. And by keeping them in one health system, that may help reduce some of the costs. And that's really, it's just a difference. It's a change in delivery. That's why I bring it up. Thank you for asking.
I just want to add one thing to that. You know, the payment stream that you get, going to a single organization does help with decrease in fractured care, right? Because we're communicating with each other, we have a common medical record and taking care of the patient population. But I think the challenge is that most seniors, I'm trying to deal with my in-laws right now with this, most seniors don't really understand it, and they don't really trust it. And you know, if you turn on the TV Saturday mornings, if I hear one more Humana Medicare managed care commercial, I'm going to just scream. And they don't really understand it, and what they don't understand, they're afraid of. So I think we have to do a better job. There needs to be resources dedicated to helping them understand. It can't be Joe Namath or some other guy on TV trying, you know, they feel like they're getting popped. So I think that's where the opportunity is to move that dial, because I do think Medicare managed care, and even, you know, the Medicare for all that people are talking about, it could be, you know, a Medicare for all managed care type. It could be successful for the United States, but people have to trust it before it's going to ever move the dial in.
And you have to be careful that some of these Medicare Advantage programs, while you see, oh, I'm going to get free vision, I'm going to get free dental, well, you might have a greater copay depending on your illness. You know, you might have to pay more out of pocket. And so those are some of the things that Patty was saying, that you really need to be educated about the insurance program that you pick. And what's interesting with Medicare Advantage, you don't have secondary. You know, so there's nothing. You either have this one payment or none. And with traditional Medicare, what seniors have today, you have kind of carte blanche, and then you have secondary to fill in those gaps that maybe Medicare didn't coverage. But with Medicare Advantage, you don't have that. You have just that. So that's something to keep in mind. And that's why I bring that up, because there's some things that's changing the delivery system, changing the payment system, and we need to learn about that, and then we all need to work together to help people better understand it.
I'll just put in a plug for SHIP counseling, the senior health insurance program. So one of the things that we do is we have folks who are licensed and certified as insurance counselors, and so most communities have someone who does SHIP counseling, but this conversation is exactly why it's needed. People need to, because some of those counseling appointments will go on for 2.5 hours trying to explain all the different options. So look for a SHIP counselor if you're struggling with Medicare questions.
We have them in rural communities too. No, I'm just kidding. I wasn't putting a plug in for my rural community.
Well, thank you. Thank you very much. And I think we can kind of stay and ask lots more questions. Hopefully you guys will be around for lunch if anyone has any additional questions. But can we get another round of applause for our panel?